All right, what we're going to do today is we're going to get started with the reversal agents first, okay? And then we're going to go talk about monitoring, okay, about neuromuscular monitoring. It's a more advanced lecture, so I want to do that one last, after we talk a little bit about the basics of reversal first. Okay? All right, so let's start with the anticholinesterase drugs. We're not going to go into cholinergic agonists too much, but we're going to talk mostly about the anticholinesterase agents. The way you actually find that most of anticholinesterase agents usually have stigma inside of it. So neostigmine, pyridostigmine, the only exception, of course, is edrophonium. Okay, but anytime you have a stigma inside of it, it's pretty much an anticholinesterase agent. The key points that we're going to go over is we're going to go into mechanisms of action, classification, structure, activity, pharmacokinetics, pharmacologic effects, clinical uses, and then what happens when you have overdoses, and then how you actually treat some of these problems. The actual physiology is something that pretty much we've already reviewed, but we'll go in a little bit more detail. The normal mechanism for neurotransmission between the muscle and the nerve, which is the alpha motor neuron, is the transmission of acetylcholine across the synaptic cleft. And once it binds to the 2-alpha subunits of the acetylcholine nicotinic receptor, it causes the muscle to initiate its depolarization and eventually causes contraction. What terminates the activity is that the acetylcholine molecule must come off. But now as it comes off, it needs to be broken down right away. If it does not get broken down, acetylcholine will then rebind to the actual acetylcholine receptor and cause reactivation. So you have to have a very rapid termination sequence to take place. And the main molecule that does that is actually almost directly attached. It's an enzyme that's directly attached to the acetylcholine receptor called acetylcholinesterase. The acetylcholinesterase has two components to it. Okay, it has a esteric site, and it has another site over here that accepts more of the anionic site of the ammonia, which is negatively charged. So if you look at the acetylcholine molecule, it fits in very nicely, and it's cleaved and broken into acetic acid and choline. Okay? So that's the mechanism behind it. Remember, what an enzyme basically does is it's a protein that is set up to accelerate a breakdown process that would normally occur fairly slowly. Now, one of the issues that was not understood until recently is that acetylcholine has this mechanism not only of a binding to postsynaptic receptors, but also it has the ability to bind to presynaptic receptors and cause effects. When you give anticholinesterase agents, basically that these inhibit the acetylcholinesterase and shut them down, what happens inside the synaptic cleft is you get an overabundance of acetylcholine. Well, that's great if you're muscle relaxed, because if that person has already neuromuscular blocker on board, it will begin to compete and push off the agent. And that's why we do it. We're actually giving this agent so the acetylcholine will be in high enough concentrations to literally compete and push off the neuromuscular blocker off. The downside to it is that excessive acetylcholine will now have other sites that it normally would not bind to. Most of the time, acetylcholine stays in low enough concentrations that it doesn't bind to the presynaptic site. It really leaves that site alone. It only wants to bind to the postsynaptic site. But once you start binding to the presynaptic site, the reason it's doing that is it's a closed-loop inhibition system. It's trying to shut down the nerve to send any more acetylcholine into synaptic cleft. Okay? So when you give that anticholinesterase agent to that individual, if you give it too much in the situation, you may actually have such an abundance of acetylcholine that you may actually cause now the muscle to become weak again, okay, which is kind of strange. But we didn't understand that until recently. Okay? So hopefully that'll make a little more sense. So this is where the acetylcholinesterase is responsible for cleaving the acetylcholine into acetate and choline. Now, acetylcholinesterase basically are agents that are anticholinesterases that work to inhibit the enzyme acetylcholinesterase. It's really nonspecific to the site sometimes, and it causes a rapid rise in acetylcholine at the junction site. And this is what I was talking about, that it accepts both pre- and postsynaptic effects. It may have direct effects on the neuromuscular junction, which is negative in the sense that if it's presynaptically, it's going to cause weakness. Acetylcholine, of course, will compete for the receptor sites and will work against competitive agents. Now, will it affect poisons that are irreversible? The answer is absolutely not. And you actually will make the situation worse by giving this kind of agent. Acetylcholinesterase enzyme inhibition inhibits the enzyme acetylcholinesterase, which is a true cholinesterase, which can be found in several areas. It can be found in the neuromuscular junction, which I just described to you. But the other important site that you really have to understand, it's found at any site that's outside the central nervous system that is in the pre- or post-ganglionic sites, okay, that have acetylcholine as the main neurotransmitter. So if that means the parasympathetics are both located in the pre- and post-ganglionics. The sympathetics are only in the pre-ganglionic. Okay? But it does affect those sites. But it's only outside the central nervous system. And the answer is, why is it outside the central nervous system? Because all these agents are charged. Okay? All the anticholinesterase agents are charged with an ammonium, usually a quaternary ammonium, that does not penetrate the blood-brain barrier. Okay? Not all of them, but most of them. Okay? Acetylcholinesterases are responsible for rapid metabolism of acetylcholine. They actually break down in 1 minute they can break down about 300,000 acetylcholine molecules just by themselves, just one. So that's a pretty impressive enzyme, pretty effective. Inhibition leads to a rapid rise in acetylcholine molecules at the junction sites, which is, I'm trying to reiterate that. Now, how the acetylcholinesterase can be inhibited can be either reversible or irreversible. The reversible ones, there's two ways of doing it. There's carbamylation and the electrostatic binding. Carbamylation is done by the two intermediate acting drugs in the sense of onset, which is neostigmine and pyridostigmine. They inhibit the breakdown of acetylcholine by basically converting the esteric site into a carbonylated compound, which means that they add a COOH group to it. Okay, so they add a carboxylic acid group to it and change the enzyme and make it less accepting of acetylcholine molecule. So they actually inhibit by changing the disposition of that protein. On the other hand, our friend edrophonium does it by electrostatic binding. So this molecule just is acting like a blocker. It gets in the way. Okay? But it's a reversible attachment. Because it's so fast, the reason it's so fast is because it just binds. It doesn't have to go through the process of adding a subunit to the molecule. So the onset for edrophonium is very short. It's 1 to 2 minutes for the effect. But if you give neostigmine or pyridostigmine to somebody, you're looking at onsets of anywhere between 7 to 11 minutes. It takes a long time for this reaction to take place. Does that make sense? Okay. Now, you can have, the classification for the anticholinesterases can be either reversible or irreversible. Reversible ones are what we're going to use in anesthesia, which is either the carbamylations or the electrostatic binding. The irreversible inactivation, on the other hand, is something that the military has to be exposed to because they have people that are trying to gas them and stuff with things like organophosphates, which are readily available in most countries because we use them as pesticides. So organophosphates, what they do is they phosphorylate onto the esteric site. Okay? And once they phosphorylate to the esteric site, it's an irreversible bond. The only way to get that acetylcholinesterase back is it's got to be reproduced. It's got to be redone again. Okay, so it has to throw the other one away and start over again. Okay? This dose response curve shows you that there's a different mechanism for edrophonium. You can see the slope of attack is different. Okay? Anytime you see a slope that's the same, but if you can see the pyridostigmine and neostigmine, they had the same slope, but they have different dosages, that just means there's differences in potency. But their mechanism is going to be pretty much the same. If you look at edrophonium, its angle of slope of attack is different, which indicates that its mechanism of action is actually different. That's how one of the reasons that we can actually figure that out pharmacologically. I thought that was kind of interesting, something to show you. Now, the formation of carbonyl esters are, the major ones are physostigmine, neostigmine, and pyridostigmine. Neostigmine is what we use clinically most. Physostigmine is a very unique molecule because it's very helpful in the sense that it is one of those molecules that actually can penetrate the blood-brain barrier. And we'll talk about a little bit later how it can actually reverse some of the effects of some of the anticholinergic agents. It produces a reversible inhibition of acetylcholinesterase by formation of carbonyl ester complex, competitively substrates for the acetylcholinesterase enzyme, and works postsynaptically mostly in these agents. Formation of carbonylated acetylcholinesterase cannot hydrolyze acetylcholine until the carbonylate enzyme bond dissociates, which could take a while. The complex has a half-life normally around 30 minutes. So if you're talking about how long duration you're looking at, it's 3 times that, so you're looking at about 90 minutes for most of these agents. Now, irreversible inactivation such as organophosphates combine with acetylcholine to form a stable inactive complex using phosphate. This is what this is right here. Okay? The typical things that sometimes medications that will do that, which we want for like glaucoma treatments, are ecothiopate. Okay? Ecothiopate, the only problem with that is that it can get into your bloodstream and cause problems with weakness, and something that you might want to consider if that person's on it. The other major poisons that we see here in Florida are parathion and malathion. Okay? And these are very, very nasty drugs that are basically insecticides. The nerve agents that were used in World War I, such as tabun and sarin, which was used in World War II. And then you have soman, which is very potent. Soman was actually used by the terrorists in Japan for the attack the subway system there. The acronyms for the organophosphate poisoning is called dumbbells. These are the kind of reactions that you'll see. And again, this is one thing is I'm teaching a little bit about military medicine, but really it's going to tie in with some of the other things that we see, which is what we see poisonings that happen under anesthesia. Dumbbells basically means diarrhea, urination, meiosis, bronchospasm, bradycardia, excitation of skeletal muscle and central nervous system. You get lacrimation, sweating, and salivation. The antidote for these kind of situations is atropine or pralidoxamine. That's what's usually used by the military. Atropine is not as effective as breaking down the phosphorylated compound that pralidoxamine is actually more effective. In patients with normal renal functions, there's really no significant pharmacokinetic differences between the anticholinesterase drugs. After a bolus, the plasma concentration of neostigmine, edrophonium, and pyridostigmine reach a peak and decrease rapidly in the first 5 to 10 minutes. The volume distribution range is actually just through the extracellular space, so it's 0.7 to 1.4 liters per kilo. And the elimination half times pretty much are all the same for all these agents, between 60 to 120 minutes. So one of the things that you can look at, some of the book mentions that if you're anephric, that your elimination half time is significantly prolonged. So all these drugs, as you can see, the patient that has elimination half times that are normal, it looks like 110 minutes for edrophonium. But the anephric, it looks like 206 minutes, so it's doubling. So that's one thing you have to be careful with, that when you have somebody that doesn't have kidney function, you should expect that these agents will last a lot longer than you should expect. Now, the anticholinesterases, lipid solubility is very questionable. It's actually very poorly lipid soluble because all of them have a charged ammonium group. Okay, so it's the N. Okay, is charged in each one of these. The first one on top is edrophonium. The next one's neostigmine, and the last one below that one here is actually pyridostigmine. Okay, all of them are poorly lipid soluble. It's pyridostigmine, neostigmine, and your edrophonium. All these are poorly lipid soluble, so they don't enter the GI tract. So if you were to ingest it orally, this wouldn't be a problem most of the time. And if you got it into your IV, it still would not penetrate into your central nervous system, which is a good thing. There is tertiary amines that are available. Okay? And actually, it's a very useful drug. Okay? This can actually reverse the cholinergic crisis. The patients sometimes will receive atropine or scopolamine that penetrates the blood-brain barrier also. These are also tertiary amines. And they can reverse the effects. So physostigmine is one of those very, very helpful drugs. It's called antiliriums, the other name for it. It has no charge. It's lipid-soluble. It does readily absorb through the GI tract and readily crosses the blood-brain barrier, which is why it's effective into the central nervous system. So physostigmine will have effect inside the central nervous system. The onset of action that you see with these different agents is much more rapid with edrophonium. Edrophonium has an onset of 1 to 2 minutes, and it's due to its different site of action. Neostigmine, on the other hand, and pyridostigmine have a much more prolonged onset of action, and especially neostigmine has an onset of around 7 to 11 minutes. Now, when you read this stuff, you go like, well, who cares? I mean, it doesn't really matter. It actually matters quite a bit. When you finish your case, when you're done, some people have this intense fear that if they give the reversal right when the surgeon's working, that the person's going to get really tight in their muscles, and all of a sudden it's going to get up and move out of the bed. Okay? Or the patient's going to buck and cough. Okay? But that's the wrong thing to do. If you then wait till the surgeon's completely done, puts the last staple in, and then you reverse, now you've got a drug that's going to set up maybe in 11 minutes, and you're extubating at 5. You've got a big problem on your hands. You've got a person that's partly reversed. So you really have to think about this, keep it in your mind, and then you start reversing when the surgeon starts putting the first stitch in the muscle. Because that's how long it's going to take him to get done. It's going to take him about 7 to 8 minutes or more, depending on how big the incision is. So keep that in mind. You have to keep in mind the onset of action. Okay? So this is a nice picture. This is a little confusing for the initial student, and it confused me initially too, because this is the picture I remember studying, and ancient times, which was 20 years ago, we were told that edrophonium didn't last as long as neostigmine. Recently, they found that it's about the same. So there's no difference in duration of action. If you look at this graph, you would say, well, you know, the onset time's much more faster, but it also looks like it's wearing off faster. In reality, it tapers off, and the line of slope of elimination is the same, so the medications pretty much stick to the same duration of action. When they actually did a new study, they found that edrophonium lasts a little bit longer than neostigmine. Okay? So the duration of action is affected by the rate of disappearance of these drugs from the plasma. The duration of action of most of the anticholinesterase drugs are similar, between 60 to 76 minutes. Renal clearance makes a big importance. Okay? Renal clearance accounts for 50% elimination of neostigmine, and accounts for 75% of elimination of edrophonium and pyridostigmine, clearance of these agents is prolonged renal failure, and the plasma clearance of the anticholinesterase is prolonged to a greater strength than the non-depolarizing agents, which can cause some problems. Metabolism is by hepatic. Metabolism is by the neostigmine, is about 50% of it, and it's only 30% with edrophonium and pyridostigmine. Now, if you have different age groups, the onset of action is actually more rapid, and with less of a dose with neostigmine in children and infants. There's no differences in edrophonium because it's a different way it works. In the elderly, you have the duration of action is prolonged because in the elderly, their volume distribution is smaller, and so you'll see that the pyridostigmine and the neostigmine have a duration of action that's prolonged. That the edrophonium does not. So edrophonium is really unchanged in the patient's age. It doesn't really matter. Pharmacological response. The response produced by these agents reflect accumulation of acetylcholine molecules not only at the nicotinic muscular site, okay, the neuromuscular junction site, but also at the muscarinic sites that are found in the parasympathetic system, as well as the presynaptic sympathetics. But it really doesn't affect the sympathetics that much. It really affects more the parasympathetics. And these can be very dangerous, undesired reactions, which I'll show you in a minute what can happen. The nicotinic-cholinergic receptors are the ones that you care about, the ones that you really want the therapeutic effect is in the skeletal muscle, which you normally would increase strength, okay, when you reverse. The downside to it is if you give too much reversal, you can actually get an overflow of acetylcholine, which then increases presynaptic binding, which increases weakness. So it's one of the few, this is again a drug that has two effects. Okay? It should make the person stronger, but at other times it can make you weaker. And actually it'll actually mimic a non-depolarizing agent. And I'll show you why that is later on when they do the monitoring discussion. Okay, so I've given you a little bit of visuals for the people that like visual stuff. The sites where you actually have acetylcholine molecules, these top two rows are muscarinic sites, which is you have your parasympathetic, preganglionic, and your postganglionic. And your sympathetic preganglionic does have a muscarinic site, so it does get affected by your acetylcholinesterase agents and anticholinesterase agents. And then you have your alpha motor neuron. So that's your major sites. So let's say what happens in this situation. What happens if you start increasing your acetylcholine at your parasympathetic sites? So you can get what's called muscarinic cholinergic effects. Okay? The parasympathetic activation will cause severe bradycardia. It's so profound that it causes asystole. Okay? And it's very difficult to reverse. And I've actually not seen it, but I've heard it from other people that have actually made a mistake, that they've actually injected the medication and the patient's heart stopped, and then despite everything they did, they couldn't get the patient back. So this is a fatal error. This is a very dangerous drug if you use it inappropriately. Now, how can that happen? How can you make that mistake? The way we teach you in clinical is to always mix your anticholinesterase agent, okay, with an anticholinergic. You mix them together. It's one of the few times that I ever tell you to mix drugs. I don't like mixing drugs, okay, but I know this is the safest way. Some people actually will recommend that you give the anticholinergics first, getting the heart rate up, and then follow it with the anticholinesterases. I have a real problem with that because at 2 o'clock in the morning when you're tired and you pick up the wrong syringe and you forgot that I have to give the anticholinergic first and I give the anticholinesterase first, I kill the patient. That's where the problem is. Okay? So for that reason alone, I tell you, don't do that. Okay, just mix them together and live with what you got. Okay, so it's just I think it's a tale of concern. I know people are going to make mistakes, but the way I try to do it is eliminate the errors as much as possible. Okay, and I know I get tired too. I mean, and I've made my own mistakes in life, and thank goodness nobody's ever gotten hurt from it. But you still worry about. The little mistakes can make a huge difference at times. Usually in anesthesia, the good thing about our job is that it doesn't take one error. It usually takes 3 errors for something really bad or catastrophic to happen. It's usually an error in judgment, an error in action, then an error in manipulation or doing something. So just got to be aware of that. And anytime, and just realize that you're a human being. You are going to make mistakes, so you start putting systems on yourself to protect the patient from making errors. That's what pilots do. Pilots are really good at what they do, but they also realize that they can make mistakes, and that's why they have checklists all the time, just to remind them of everything that they have to do. Because everything if everything becomes a routine after a while, what do you end up doing? That's fine. It never happens. Don't have to worry about it. I don't have to do that checklist anymore. I don't have to check the elevator. The elevator's always on. You get up in the airplane, all of a sudden the elevator's no longer on. Okay? One of the reasons that this kind of stuff is important, and I'll give you a story that's actually true. In World War II, one of the things that they made the pilots do when they got on the fighter pilots get on, is that they would walk around the Spitfire before they'd get up and fly to make sure that everything was functional. And one time they got attacked by the Germans, and one guy went around, checked his machine before, and these guys were strafing running. Okay? Well, the other guys ran into the airplane, jumped in, and took off. Both guys that took off were dead. Because when they took off, their rudders were were locked. So they died. So much for rushing. Whereas the other guy that checked his equipment, pulled the rods out that had locked the rudder, he got in an airplane and took off and attacked the Germans. So it's a tale of do the same thing over and over again. No matter how much in a rush you get into, you've got to stay in the routine. The same thing we do to you in anesthesia will make you do the same thing over and over again. Okay? All right. What you also get from this is, besides profound bradycardia, is that you get profound salivation. You get meiosis, which is not so much of pain, but it's more of a discomfort for the patient. Hyperperistalsis, which can give you severe diarrhea and increase the hyperemesis. And it can cause bronchoconstriction. Okay? This occurs with lower acetylcholine concentrations necessary for the effects that occur at the autonomic ganglia than at the neuromuscular junction site. So you tend to see this taking place already before the effects on the muscle is taking place. Okay? So you can't lowball it. In other words, you can't decrease your dosing and hope that the muscle is going to reverse. It's not. It's going to get the other effect first. So because of that, you've got to give an anticholinergic agent along with anticholinesterase drugs to prevent this from happening. Okay? Remember, the anticholinergics do only work where? They only work at the muscarinic sites. Okay? So the anticholinergics only bind to muscarinic acetylcholine receptors. They can't bind to nicotinic receptors, because then they would become what? They would become muscle relaxants. They would become neuromuscular blockers. Okay? So the anticholinergics are just different enough that they can only bind to the muscarinic acetylcholine receptors. Now, what you see with cardiovascular effects is that it affects accumulated acetylcholine changes and decreases bradycardia. Blood vessels can cause vasodilation, and it causes, to the point of bradycardia and bradydysrhythmias, that tend to be severe AV nodal dysfunctions, okay? And they can reflect slowing conduction to the AV node. And the effects are blocked by giving the anticholinergic agents. Bradycardia and or sinus arrest may occur with a denervated heart, which is kind of a concern. The reason that's a concern is because even if you give the anticholinergic agents to that individual, that person can still go asystolic on you. Okay? So reversing people that have had cardiac transplants is a little bit tricky. Okay? You've got to sort of be careful. So just be aware of that. I personally have taken care of a lot of people with post-heart transplants, and most of the time it's minor procedures, so you don't need to use muscle relaxants. So the tail is avoid the muscle relaxation so you don't have to reverse. Otherwise, you're sort of stuck. The muscarinic effects also decrease SVR. They can actually increase your PVR, your pulmonary vascular resistance, and increase your coronary resistance, which may increase the risk of ischemia in some individuals. The GI effects usually is more of an irritation. The person will, when you give the agents, will cause severe diarrhea right on the bed. Okay? So the person will empty their bowels right on the bed. Nurses won't really be happy with you, because they'll have to change the patient or clean the patient while in the operating room. Okay? But that's one of the side effects of the agents. They also may increase your incidence of postoperative nausea and vomiting. But I think that's played up way too much. If you have somebody who's weak, what's more dangerous? Somebody who is adequately reversed or somebody who's weak and now is nauseous because he can't see? I would say that it's much more dangerous to have somebody who's weak, because now he can't protect his airway. At least this person, yes, they may have vomiting, the incidence may go up, but everything in anesthesia increases the incidence of nausea. Okay, narcotics, nitrous oxide, volatile anesthetics, pretty much every single agent that you use. The only agent that's not is propofol, pretty much. But everything else is going to cause an increase in nausea and vomiting. Considering when patients that are being discharged from day surgery, we don't use any more almost non-depolarizing agents. Okay? We use the depolarizing agents in day surgery because we know that we don't have to reverse them. Okay? Because most day surgery cases don't require muscle relaxation. And if you need muscle relaxation, we do a regional block for that individual. So that way we can get them out more quickly and more pain-free. So really, really, really be careful. If you're going to start using these cases for day surgery, non-depolarizers can be a big problem. And some of the studies are starting to show that there's increased risk of problems. Some of the recent studies have also shown that that you get an increase in anastomotic leak with neostigmine. Personally, I think that's a study that was done by a surgeon trying to prove that anesthesia is always screwing everything up that he did. So, I have sort of an issue with that. The studies that were done after that were really not proving that. So it might be the guy wasn't putting good sutures in place, and that's he was just trying to blame the anesthesia department. So I have an issue with that. Neostigmine may be effective to treat paralytic ileus or atony of the bladder. It has been done for that and used in long-term treatment for people with this kind of problems. Now, unfortunately, these agents will cross over and will bind to plasmacholinesterases. Okay? So that's a big concern. I'll give you a classic picture. This was really a situation in which I should have been called on, but somebody just decided that they wanted to do it on their own. So the surgeon was finishing up, and after the surgeon was was finished up, he had closed up the abdominal wall already. The person had reversed the patient. Okay? After the surgeon was completely done with the skin, he's down to done. He says, "I'm done." The nurse looked at him and says, "Oh, we have the lappers, we have one of the sponges is still missing." So the surgeon turned around and says, "Okay, well, I'm going to go back in." I left it in. So he unclipped and opened up the belly. Well, the patient started moving a little bit. Surgeon starts screaming, okay? And at that point, you've already crossed the bridge. The bridge behind you is burned down, and there's no way to go back. The only way you're going to go back is by increasing your volatile anesthetic and getting them deeper. That's the only thing you can do. Unfortunately, this individual didn't remember this lecture, and they gave succinylcholine because they were going to muscle relax the individual. Well, it was great. The muscle relaxation was intense, beautiful, and lasted 55 minutes. Okay? Because the anticholinesterase agents will knock out the plasmacholinesterases. And it basically made that person a heterozygous, atypical pseudocholinesterase deficient patient. Okay? So just be aware of that. Okay? This is especially seen when you're giving neostigmine or pyridostigmine, not so much with edrophonium. Yes? Why would you give rocuronium again? You've already reversed. That patient was already reversed, so you don't want to add another, or you can't add the agent on again. Okay? It won't work. Okay, and if it does work, then you're going to have a prolonged blockade too. So at that point, that's why I said you've already crossed the bridge. The bridge is burned down. There's no way to go back. You can't use the non-depolarizing agents or the depolarizing agents. You can't use either one. You're sort of now stuck with your volatile agent to help keep that person relaxed. Okay? Yes? How many times should you give it? See, that's what the next lecture is about. Okay? And I'm getting to it because that's a very important topic. A lot of people have that wrong, so we'll keep going. We'll come back to it. If you have a disease process like myasthenia gravis is a disease where you have antibodies that attack the acetylcholine receptor and destroys them. You can develop what's called cholinergic crisis. It's this risk associated with giving these patients anticholinesterase drugs who have also received non-depolarizing agents. They get a prolonged neuromuscular blockade. It's been reported when neostigmine is given to a myasthenic patient after rocuronium, which is kind of strange. Like, how will you get more prolongation, right? Well, what happens in this situation is that there's not any more acetylcholine receptors. There's nothing to soak up the acetylcholine postsynaptically. So when you give the anticholinesterase agent, it's very potent. And you get a very high level of acetylcholine now sitting in the synaptic cleft. So that then binds to the presynaptic site and shuts down the nerve to transmit acetylcholine out of it. And it gives that person a very flaccid paralysis or what's called a phase 2-like blockade, which basically appears just like the non-depolarizer. Okay? You get fade, you get potentiation, all that stuff is possible, but it is causing weakness in that individual. Okay? The excess, and if you give that person edrophonium, you'll see that the flaccid paralysis will actually make it worse because edrophonium works mostly at the presynaptic receptors as well. Now, myotonia. Myotonia is something that can occur Anticholinesterase agents share some of the effects of succinylcholine because they can produce fasciculations and they augment the twitch response. Used with caution with patients that have absolute contraindications to succinylcholine. But I have personally never seen a problem with that, okay? And I've reversed people with all these problems in the past and never had any kind of like because it's still working at the neuromuscular junction site. It's not working in the peripheral sites. Because these problems are what kind of problems? These are problems with, they're not junctional, but they're the ones that are outside the junctional sites. Okay, the outer junctional sites. Okay, these are the sites that are the neonatal receptor sites. Okay, but if you give that person anticholinesterase agents, that's still working at the neuromuscular junction site. Okay, so that's a narrowed problem. So I've never seen that, okay, myself. So when I read that, I was kind of interested, and then I went back and read some of the other articles that were associated with it, and they came up with very few reported cases as well. So it may be a theoretical concern, maybe something in the back of your mind to be worried about, but I've never seen it being much of an issue, and I've given reversal to all these people if we gave these agents. Now, anticholinesterase indications. Normally, we give them for peripheral actions, which is we want to reverse neuromuscular blockers. Edrophonium, neostigmine, and pyridostigmine will do that. We can also use it to reverse central effects of drugs that actually can penetrate the blood-brain barrier, like atropine and scopolamine. I had a patient about 2 days ago that came out confused. And I didn't realize that somebody put a scope patch on the patient. And we finally gave physostigmine to that individual, and everything got better. So these centrally acting agents are very useful. Treatment of disease states can also be important for myasthenia, glaucoma. You can treat paralytic ileus and atony of the urinary bladder, and also we're now beginning to treat Alzheimer's disease with this as well, because Alzheimer's is a lack of acetylcholine available at the sites in the central nervous system. So we're now using agents that are central acting agents like physostigmine that are longer acting. There's other things that are like physostigmine that are longer acting that we use now for clinical use for Alzheimer's. If you look at the first one, let's look at antagonizing or assisting reversal of neuromuscular blockers. This is the question you just asked. So let's go through it. Edrophonium, neostigmine, and pyridostigmine are basically used to reverse the effects of non-depolarizing agents. In the United States, pretty much edrophonium has been recently taken off, so I think it's still useful to know this because it might still come back. But neostigmine is the major agent that we use in the United States. Okay? Pyridostigmine is so slow in onset that we don't use it clinically, so it's a theoretical thing. It might be useful in long-term treatment of certain diseases, but really neostigmine is a major player in anesthesia. Basically increases the amount of acetylcholine at the nicotinic receptors, which results in giving these drugs increases in chances of the two acetylcholine molecules binding to the alpha subunits of the nicotinic receptor and competitively binding and pushing off those agents. These drugs are typically given at a time when spontaneous recovery is occurring, and therefore recovery from short or intermediate acting neuromuscular blockers occur much faster than recovery from long-acting agents. Okay? So one of the things that we've learned over the last few years is that even with appropriate use of agents for neuromuscular blockers, the long-acting agents have a much higher risk of complications. Okay? Because still, what's really happening, what they're not telling you, okay, is that people have very poor clinical habits. Okay? They are not looking to see if that person's been adequately reversed. They are making assumptions that are incorrect. It's part of the training was bad, that they were trained. Okay? It's part of this idea that, well, you know, it's just the thing wears off. After 4 hours, it'll be fine. I'll give you a classic. I had a woman that I took care of. I wouldn't take care of. The other team had taken care of, but I came in the evening like I normally do, 3 o'clock. Okay? And they gave me a report, and that was it. And I came by, checked on the patients, and then I got called by the recovery nurse telling me that this patient was not doing very well. Though I was not really complaining about anything, but really was kind of nauseous and seemed to be, you know, kind of, wasn't really waking up like she should be. So I walk over, And the nurse starts talking to her, and she says, "Are you nauseous?" And she just shakes her head very lightly. And she's saturating 100%. And I look at her and I said, squeeze my hand. And she squeezes my hand, but it's really, really weak. But she can still squeeze her hand. So then I pull out the chart. They had given her 25 milligrams of atticurium 4 hours before the end of the case, at the beginning of the case. And then at the end, they had not reversed the patient. So I said, I know what's going on. So I called the person who had done the case, pulled them back into the room, said, bring reversal. Because that individual really, truly believed, like some of you may still, after you finish this lecture, because some of you will be told that you don't have to. Brought this person back in, and I showed her to her, said, look, give the reversal agent, and let's see what really happens. You basically stated to me that you don't believe that you need to give reversal because the person has waited 4 hours, and they should have metabolized their drug and should be fine, right? This is a 24-year-old woman. Should have metabolized it, they're fine. But in essence, not everybody metabolizes these drugs at the same rate. So we gave the reversal. As soon as we gave the reversal, in 7 minutes, she was opening her eyes, looking around, moving her arms, and she was getting very agitated. And she looks at us, I couldn't really move. She sat there in the recovery room for 2 hours. So she had already been, in other words, they had waited for 6 hours before we gave reversal. And that person was still weak. Okay? So don't believe just because you have long durations between the dosing. If you don't check your train of 4, you really don't know where you're at. Okay? And that's a real tale. Whoa, that person could have died. Okay? That person could have died. If that person would have been 80 years old, that person's FRC would have been pretty low. They would start desaturating, and you would have to reintubate, and the person might have died in the process. Okay? Being young and strong, the diaphragm comes back first. So that person was able to maintain their ventilation adequately. But I can tell you, she was not happy. She was not a happy camper. She felt like she was restrained and couldn't move. So, and as soon as we reversed her, what happened to her nausea? 0. Okay? Because the reason that you get nausea with non-depolarizing agents is that your eye can't adjust. So when you're looking at people, you can't see who they are. Okay? When you get the reversal, all of a sudden your pupils can work again, and now you can actually adjust, and now you don't feel like you're seasick. Okay? So it makes a big difference. Okay? Yes? That's what we'll talk about. We're going to keep going with that. Okay? The onset and duration of action of edrophonium is more rapid onset and action, but all 3 agents have similar duration of action. Okay? Equivalent doses of edrophonium is less potent than neostigmine. It's almost 10 times less potent. So the dosing is around 0.5 milligrams per kilogram IV. Neostigmine is 0.04 milligrams per kilogram IV is your reversal. Okay? And neostigmine appears to be preferable when you have greater than 90% twitch depressions to be antagonized. Pyridostigmine goes at 0.21, which is the most potent of these agents, of course, is which one? Neostigmine. That's why we use it. Okay? So potency is 10 times stronger than edrophonium, and it's about twice, well, it's more than that. It's about 5 times stronger than pyridostigmine. Now, you have to mix your mixture. You always mix your anticholinesterase agent with your anticholinergics. Okay? I tend to mix my agents together in a slightly different fashion than other people, and I'll show you what I'm talking about. Edrophonium has to be mixed with atropine. Okay? The reason being is the onset speed is very fast, so you need an anticholinergic that sets up just as fast. So, and that's atropine. Atropine sets up quickly. There's a real downside to that, though, because what you're doing is you're giving a centrally acting agent. So atropine can actually get through the blood-brain barrier and cause problems. So I don't like doing this. Have I used edrophonium? Yes. But you've got to be a little bit careful with it because of the atropine. Okay? What we tend to do is you can actually mix neostigmine and atropine, and you dose atropine is about 1/2 the dose of neostigmine. You get initial tachycardia and late bradycardia, but most of us will mix neostigmine and glycopyrrolate. Okay? And it's usually a 50-50 mix. Okay? So if I drop 5 milligrams of neostigmine or 4 milligrams of neostigmine, I also drop 4 cc's or 0.8 milligrams of atropine, of glycopyrrolate. So it's a 50-50 mix. If you do that, you should expect to see a 20 to 30% increase in heart rate. Okay? So if you're concerned about that, which in my population, which is the older elderly that I take care of here, I worry about that all the time. I don't want that kind of rise in heart rate. So what I do is I reduce my glycopyrrolate by 1 cc. And I only get a 15% increase in heart rate by doing that. Okay? So if I give somebody a full reversal dose of 4 milligrams of neostigmine, instead of giving the whole 0.8, I would give 0.6 of glycopyrrolate. The lowest I will ever give a glycopyrrolate, and I'll show you another slide about that, is 0.4. You cannot give less than 0.4 of atropine or less than 0.4 of glycopyrrolate. Because if you only partially block the cholinergic site, okay, you only bind, let's say, 50% of the receptors. The other 50% now are hyperactivated. And you can get a much more profound bradycardia if you get a parasympathetic activation. So just be careful that you've got to give enough anticholinergic to wipe out those receptors so you don't have problems. Okay? That's why I'm not a believer in titrating. It doesn't make any sense pharmacologically. How can you titrate a drug if you're giving it to knock out all the receptors? You have to give it in volume to knock them out. Okay, so if you see me give reversal agent, I will never titrate. I'll just go, boom, we're done. I figured out my dose, and I just go with it. Okay? Other people will titrate it, and then they'll see bradycardia. Well, the reason they're seeing bradycardia is because they've only given half the glycopyrrolate, so those people better give the 50-50 mix. Okay? So that's why you have to give 50-50 mix. You do it that way. In my way, you just give 1 cc less. Never seen bradycardia. Never seen anybody's heart slow down. Nothing. It's always been about a 10 to 15% increase in heart rate. Okay? So, and I've done that for 20 years and never had a problem. Pyridostigmine and atropine can be used for glycopyrrolate. Again, it's what you should expect. Most people would use glycopyrrolate with pyridostigmine. Events that influence the reversal. The intensity of the neuromuscular block at the time of reversal is very important. If you have no twitches, you should not reverse, period. You're not going to do anything. You can't compete against, huge amounts of neuromuscular blockers. So you've got to wait till you get down to at least 2 twitches. Once you get up to 2 twitches, then you can reverse. Okay, it's preferable to wait even to 4 to reverse. It's safer. But as long as you have something, you should be very careful. Everybody gets, I can tell you what it's like in clinical. People are looking at you like, oh, you're the stupid student, or you're the stupid new doctor that came into the town, and you gave too much neuromuscular blocker. Because you know what? You're going to get caught with your pants down when you do your first case with a surgeon that does it in 15 minutes. Okay? Because when you work in residency programs, a surgeon takes an hour and a half to do a gallbladder. Okay? Versus here, they do it in 15 minutes. I had an appendix the other day that the guy did it in 7.5 minutes. Okay, an appendix. Laparoscopic appendix was 7.5 minutes. The student that was looking at me like, geez, Dr. Nolan, I'm glad I didn't get the non-depolarizer. I said, that's why I'm telling you, just dive the people deeper with a gas. We're going to be out of here in 7.5 minutes. So a very different practice. Okay, but if you were used to being a resident, oh, everybody goes after cream, 30 milligrams, cool. And then the surgeon says, I'm done. 7 minutes into it. You're going, what? Now you got to sit for 40 minutes. Okay? And of course, all the nursing staff is walking around looking at, what are you doing? How come the guy can't wake up? I can't reverse yet. They don't know anything about reversal. They just think you're a dumb anesthesia personnel that doesn't know what they're doing. Okay? And they will begin grading you. They'll look at you, oh, God, I want to go to have a cup of coffee. You're making me delayed. Now we're delayed between the next case. You can always see the griping. Okay? So you feel the pressure put on you. Okay? So you see one little twitch and go, yeah, reverse. Okay? So you reverse this person. Okay? And then all of a sudden, now that person's like, look like a dead fish. Okay? That's really bad. Okay? You just made the situation from bad to worse. Okay? So don't reverse anybody with 1 twitch. You got to wait for 2 twitches, and you got to do it right. Okay, just be patient. Okay, you made a mistake. Move on. Don't add to it. Okay, compounding the error makes it worse. What we find is that edrophonium is less effective in reversing deep blocks, which is kind of makes sense because it's not as potent. Neostigmine is much more potent for reversing agents. Things like continuous infusions of atracurium, bacterium, and pabulon. Edrophonium may be also more effective in reversing atracurium for some reason, which is not entirely clear to me. It's why they stated that in the book. I was scratching my head when I saw that, but that's what the book says. But neostigmine is actually more effective than the longer-acting agents, which sort of makes sense to me. It's just more potent. I think I'll stop here and wait for 10 minutes, and then we'll start back up, and then we'll finish this section up, and then we'll start on neuromuscular blockers next. Now, things that it can influence your reversal. In other words, it can potentiate the reversal agent the neuromuscular agent that you're using will be things like aminoglycosides. The other thing that will also make it more difficult to reverse somebody is hypothermia. And then respiratory acidosis can also increase the difficulty of reversing somebody. And hypokalemia and metabolic acidosis can also make it more difficult to reverse somebody. If you have excessive neuromuscular blockade, once acetylcholine receptors are maximally inhibited, giving anticholinesterase does not antagonize the block. So really, it's very, very dangerous to do that. So before you reverse anybody, you want to make sure that at least they have 2 twitches. Okay? If you try to reverse without checking, you may actually have persistent neuromuscular blockade despite large doses of anticholinesterase drugs. Okay? Indications to ventilate. If you see that happen to you, then just don't try to keep adding more reversal. Just give up and take the patient to recovery room and put them on mechanical ventilation and just sedate them. Make sure you sedate them, okay? Because they won't be able to move. Okay? Now, unfortunately, when a recent study was done in the United States, because this is a United States study, routine reversal is not being done. Okay? And it's actually pretty dangerous what's going on. A large clinical study, which they did actually 526 patients, examines the incidence of residual paralysis after a single intubating dose of an intermediate-acting neuromuscular blockade, and then given no reversal. On arrival to PACU, train of force of less than 0.7 was found in about 16% of the patients, and less than 0.9 was found in almost 50% or 45% of the patients, which is pretty big time, big concern. Anybody that's less than 0.9 has a higher risk of aspirating and dying. Okay, so this is a significant study showing that you have a high incidence of residual neuromuscular block. And it's been reported with anticholinesterase are omitted. Routine administration of reversal agents, however, just another caveat, does not guarantee complete recovery. And so you have to be really aware that you may not have adequate reversal even though you gave reversal to a patient. Okay? So some of the general principles to avoid the residual paralysis. 1, neuromuscular blockers should be only administered to patients who require this therapy. It shouldn't be given out like candy. I see some people believe that anesthesia should mean paralysis. It doesn't mean that. Okay? Anesthesia means that you have to you have to give the patient what he needs. Okay? And making the muscle relaxed doesn't necessarily mean that you have to do it in every case. If they're doing a foot surgery, there's absolutely no reason to paralyze somebody. I saw somebody do that the other day. They actually had paralyzed the patient because the person was moving their feet a little bit when the surgeon was working. Yeah, deepen them. Deepen the anesthetic. Don't have to give them a muscle relaxant to stop the motion. Okay? So it's just something, just got to be careful of these drugs. Don't overdo it. Okay? Dosing should be individualized based on surgical necessity, patient factors, and the presence of coexisting disease. The long-acting agents like pabulon should be avoided. The only place where we use pabulon in our system is in open hearts. That's the only place. Intermediate actions shouldn't be used whenever feasible. Clinical tests to muscle function, which is what you'll read in the books. So this is behind this new study. If you read the textbooks, they'll tell you, well, you can do a head lift, you can do a 5-second head lift, jaw clenching, grip strength, all that are perfect, right? No, those actually been found to be unreliable. they are not reliable enough to tell you that the larynx is back, which is what protects you from aspiration. To exclude with certainty the possibility of residual paralysis in patients at risk, clinicians should be using objective neuromuscular monitoring, which is the next lecture. Okay? We tend to use non-quantitative. We tend to be not a quantitative test that we're doing, but more of like a quality kind of test. Ideally, neuromuscular function should be monitored objectively, quantitatively in all patients receiving neuromuscular blockers. My thing is, if you decide to give a non-depolarizing agent to a person, then the other thing that you must have right back next to the patient is a twitch monitor. You must have that. If you're giving neuromuscular blockers and you're not doing that, to me, you're doing malpractice. You're doing it completely wrong. You need to learn how to use it. Okay? So we'll talk about that next. Principles of monitoring is objective. Quantitative monitoring of neuromuscular function should be always used if you're going to use it. Peripheral nerve stimulator units should display the delivery current output, which is important because a lot of times you don't know that your battery's dying. The only way you know is by putting the probe to yourself and making yourself pain, which it's okay if you're sadistic or masochistic, but most of the time you don't want to do that. Or you can do it to your friend. We used to do that as residents to find out how much fun it was, just how much people could take it pain-wise. The assessment of neuromuscular responses should take into consideration the muscular group that's monitored. That's also important. We'll talk about that again next hour, and I'll come back to that. We'll talk about adductor pulses versus the orbicularis or oculi. Adequate recovery should be established before pharmacological antagonism block with anticholinesterase is done. This requirement does not apply to reversal with sugammadex. So one of the things that hopefully is coming down the line is sugammadex. Okay? Sugammadex is amazing, okay, what it can do. It's a donut molecule that has a negative charge inside of it that soaks up all the positively charged molecules like your muscle relaxants that you're using. Okay? So it's really a really helpful agent. I'll show you a picture next of what it can do. Tactile evaluation of train of 4 and DBS reduces the incidence of postoperative residual paralysis with the use of clinical criteria. So that's one thing that you should at least minimally have. And the timing to tracheal extubation should be guided by quantitative testing, such as train of 4s of greater than 0.9 or DBS is greater than 0.9. During the anesthetic technique that do not enhance the effects of muscle relaxants, such as total IV anesthesia, a minimal train of 4 or 2 should be present before administration of anticholinesterases. So that's a minimum you should always wait for, at least a 2. And I've reversed at 1, and I got burned more than once with 1. So I've learned my lesson. I will follow these new guidelines and go with wait till I get to 2, even if it means another 10 minutes. Because to reverse and not be adequately reversed is worse. Now you've got a person that's flopping on the bed, and you can't do anything for them. So at that point, you've already, screwed up. If recovery to train of 4.9 is documented by MMG, which is something that you cannot do right now unless you have an MMG, which is, I'll show you what that is in a minute, neostigmine should be withheld. Okay, so in other words, in clinical practice, if you don't have an MMG monitor, which you don't here in Naples, okay, then you really have to reverse everybody. Okay, so everybody who gets a non-depolarizing agent in this county, you should be getting a reversal agent. Now, should it be full reversal or half reversal? That's what the argument is, and we'll show you what that argument will be in a minute. Okay? Administration of neostigmine to fully recovered patients may actually cause problems as they may decrease upper airway muscle activity and tidal volume, because you're enhancing the presynaptic inhibition of acetylcholine if you give to somebody who's already fully reversed. Okay? So how do you determine it with just a train of 4? So here's the reversal guidelines. No neuromuscular blocking, you shouldn't be doing it. If you have a person that has no neuromuscular monitor or peripheral nerve stimulator used, that to me, you shouldn't be doing that in the first place. The clinical tests are totally unreliable, and pharmacological should be administered routinely and only when spontaneous muscle activity is present. And then you should give full dose. Okay? But that's really bad. So I would recommend you don't do that in your practice. Okay? Instead, if you use peripheral nerve stimulators, which is subjective, okay, and I can tell you this, the train of 4 is a little bit more subjective than DBS. DBS is a little bit better, which is double burst stimulation. I know you don't know what that means yet, but we'll talk about it in the next hour. If you have train of 4 1 or no train of 4, then don't do reverse at all. Wait. When you get a train of 4 of at least 2, then you give full reversal. And then if you have train of 4 with fade, which is greater, this is less than 0.4 train of 4, then you get full reversal. If you have train of 4 with no perceived fade, then you give pharmacological reversal, and you can actually give half the dose, which is a low dose treatment, okay, for that. But you have to have no fade at all. If you have the quantitative evoked potential, which is all the different kinds that you have here, okay, it follows the same rules, except for the last one, where you have, if you can actually quantitatively measure the 0.9, if you over the 0.9, then you don't have to give reversal. That way you now know that there's no indications of reversal. You have that individual which I talked to you about, that young lady who woke up and was weak and nobody noticed it. Well, if you'd done the MMG study and found out that she was less than 0.9, you would have given her half reversal, okay, at least, and you would have gotten her out of trouble. Now, what do you reverse with? Edrophonium is one of those agents you can use. It's a quaternary ammonium. It has no carbonyl group on it, so it doesn't cause the carbonylation on the acetylcholinesterase. It's a reversal inhibition through electrostatic attachment. It has no covalent bond between the edrophonium and the acetylcholinesterase. It's just an electrostatic bond, so it's weak. Its onset of action is pretty quick, 1 to 2 minutes, and duration of action is 60 minutes. And it's most of this action is actually presynaptic. It also binds to presynaptic membranes. Edrophonium has muscarinic effects are considered to be mild, and actually some of the treatments are done without any use of anticholinergics. Okay, so this is one of the few agents that you don't necessarily need an anticholinergic associated with it, but you got to get real slow to do that. Now, the reason that we can say that is because I've used edrophonium to diagnose people with myasthenia gravis. I had a great case when I was in the ICU. I had a lady who had come in from Texas on a visit. She got intubated in the ER. We brought her to the ICU. The next day, in the morning, she was really strong, doing fine. We pulled out the endotracheal tube, and she hit all the parameters to extubation. Pulled the endotracheal tube, and 35 minutes later, she was reintubated. Scratching her head like, what's going on? Okay. The next morning, she again fulfilled all the criteria, nice and strong, pulled the tube out again. This time, she had to be reintubated again 30 minutes later. When I looked in, the vocal cords were completely opposed, which is strange. That shouldn't be the case. Okay, so we got her reintubated. I said, what's going on here? And then I watched her during the day, and I noticed that during the mornings, she was really strong, and by the afternoons, she wouldn't open her eyes anymore and look at us. Okay, and that's typical myasthenia gravis. Okay, so what I did was this time around is I gave her tensilon, which is edrophonium, slowly, without any other agent. And as I did that, all of a sudden she appeared to be much more awake. But the reason you're looking more awake is because the eyes now open up fully, and the person's looking at you like, can you please take this breathing tube out? So we pulled the tube out, and this time she did fine. She flew. Okay, it's just from the edrophonium reversed the effects of myasthenia gravis enough that her bulbar muscles were strong enough that she could maintain her respirations. Okay? And we had to keep adding the edrophonium throughout the rest of the day. And then I got a neurologist involved and switched over to a long-acting agent, okay, which can be given as long-acting agents to reverse the effects. Okay, so normal dosing of edrophonium comes in 10 milligrams per cc. Usually it's an almost equivalent dose. If you're going to say you can get 4 milligrams of neostigmine, you tend to get 40 milligrams of edrophonium to equilibrate. So these are very similar. There's just 10 times differences in concentration. You can titrate it due to its rapid onset. So this drug you can titrate because it's rapid onset. It's 1 to 2 minutes. So when people say that to you, that, well, reversals can be titrated. And my answer is, which one? And if they look at me like, what do you mean, which one? I said, well, you don't understand that, okay? You can titrate edrophonium, but you can't titrate neostigmine. Neostigmine, you can't titrate a drug that takes 8 to 11 minutes to set up. It's a non-titratable drug. As you're giving the first dose, by the time it loads, unless you're titrating every 8 minutes. If you want to call that titration, okay, then I'm fine with that. But you got to say it properly. Reversal doses of 0.5 milligrams per kilo, which if you look at a person that's 100 kilos, you'd give 50 milligrams of edrophonium, which is 5 cc's, with 5 cc's of atropine. So it's a 1-to-1 ratio is what you see. Now, neostigmine is the one that we tend to use in clinical area. It's a quaternary ammonium. It has the blue in the top. That's a quaternary ammonium. It also has a carbonyl group, which is in red. And the carbonyl group is what carbamylates the enzyme and pretty much affects the activity of the acetylcholinesterase, which is reversible. It doesn't enter the central nervous system because it has a quaternary ammonium, which is charged. Its onset of action, though, on the other hand, is very slow because the carbamylation takes time. So this is a drug you really can't titrate. It takes 7 to 11 minutes for it to load up. Okay? The duration of action is a little bit shorter than edrophonium, but clinically you can't see that. It seems like to me clinically that neostigmine seems to be stronger, which it is, more potent, so it seems to act longer to me. But in actuality, when they actually do the studies, it's a little bit shorter than edrophonium, which is around 54 minutes. Neostigmine comes in 1 milligram per cc vials. Usually it comes in this kind of vial, and the glycopyrrolate comes in a little purple vial. Okay? You get full reversal dose is 0.04 milligrams per kilo, and you get 0.008 milligrams per kilo of glycopyrrolate. The maximum dose is really 5 milligrams. Should not exceed 5 milligrams of neostigmine. Okay? If you look at a 100-kilogram patient, okay, this individual would get 4 milligrams of neostigmine, followed with around 0.8 to 0.6 milligrams of glycopyrrolate, depending on which dose you want to give. If you want to give the 50-50 dose, that's you'd give 0.8 milligrams. That would increase your heart rate by about 20 to 30%, which if you're not worried about it, you're a young person, not an issue. If you have an old person who's already up in the 80s, 90s, and you do worry about it, you don't want to go into really 120 heart rate, then I would use a 0.6 milligram dose to increase my heart rate only by about 15%. Neostigmine can't be titrated. Its onset's intermediate. Half dose for patients with train of 4 with no perceived fade can be given to patients that are considered safe. So you get 0.02 milligrams per kilo of neostigmine. But here's where the trick is, and this is where students forget. And this was going to be on your test question, I can promise you that. Okay? If you have somebody who the minimum dose of glycopyrrolate you should give is 0.4 milligrams. So if you have a 100 kilogram patient, you give 2 milligrams of neostigmine, that's a half dose, then you'd give an equal 1-to-1 dose of glycopyrrolate, which would be 0.4, which is fine, right? Well, what happens if I drop your weight down to 50 milligrams? 50 kilograms. That patient now is going to receive a half dose at 0.02 times 50, and that's going to give you 1 milligram, which is 1 cc. How much glycopyrrolate should I give? Just 1 cc of glycopyrrolate? And the answer is no. You've got to maintain the glycopyrrolate at 0.4 milligrams. So you're going to have to give 2-to-1 ratio in this situation. So you're going to have to give 2 cc's of glycopyrrolate for 1 of neostigmine. Okay? If you don't, you will find out the hard way why it's not a good idea. Okay? And if you ask that on the test, you'll find out the hard way by missing the question. Okay? So it's a way to reiterate that concept. Treatment is edrophonium for myasthenia gravis. It's a diagnostic treatment, and it's really cool when you give it. It was I always read about it, and I always wanted to do it. And one of the cool things about being an ICU doctor is you get to sort of see things sometimes that you don't always get to see anywhere else. So when we gave the edrophonium, it was amazing how much improvement that person had, and the person can immediately get better if you're giving edrophonium appropriately. If the patient's symptoms actually get worse, that means that person has actually been overdosed on anticholinesterase agents. Okay, so edrophonium will actually make that situation worse. But a true myasthenic patient without any anticholinesterases on board, when you dose them with edrophonium, they get better. Medications that used to treat myasthenia gravis that are longer acting, of course, neostigmine and pyridostigmine. Pyridostigmine is what we tend to use for long-term treatment, which is called Mestinon. Most of you know that. I've heard, at least when I remember hearing that terminology more than pyridostigmine. It's a quaternary ammonium. Reversal dose is 0.35 milligrams per kilo, or 0.2, depending on which book you read. We don't use it as anesthesia because it's too long in onset, usually plus 11 to 16 minutes. But instead, it's used for myasthenia gravis patients. You can see it comes in pill form, and it will cross over a little bit So it's really a very high potency. You would never crush this medication and give it IV because it would kill you. Okay? It would give you a gross overdose, too much. Okay? Diagnosis and management of cardiac dysrhythmias has also been used with using these agents. Edrophonium I've actually seen and used for treatment of PSVT. This was before the advent of cardizam. So I would never go back to doing this because I know how edrophonium is pretty dangerous. You can overdo it pretty easy. What edrophonium will do is it knocks out the AV node, starts slowing it down. So it does work pretty well. In WPW, it's seen to work as well. The initial dose is 5 to 10 milligrams IV, so you're looking at it's half a cc to 1 cc of edrophonium, followed by a continuous infusion. Sometimes the actual study that was done, they did it up to 30 hours, and it was effective at maintaining a slow ventricular rate with clinical improvement, and there was really no significant side effects with this technique. So pretty cool way of doing it. Postoperative shivering can also be used, but again, we don't do this again. We use meperidine, so I don't think this is a really good idea to giving physostigmine for somebody for postoperative shivering most of the time. Overdose of anticholinesterase drugs can be a real issue. Acute overdose or intoxication with anticholinesterase drugs manifests in muscarinic and nicotinic symptoms on peripheral and CNS sites. The muscarinic symptoms are simply the same thing as you get organophosphate poisoning. So you have dumbbells. Okay, you get diarrhea, urination, meiosis. Okay, that's your DUM. Your bells are bronchoconstriction and bradycardia. Then you get excitation of the skeletal muscle, which usually causes confusion, ataxia, seizures, coma, and depression ventilation. Then you have increased lacrimation, sweating, and salivation. The nicotinic sites range from muscle weakness to complete paralysis. You can actually induce a complete paralysis by overdoing the increases in acetylcholine levels at the pre-junctional sites and knock everything out. You will actually get fade, so it will actually look like the person who's actually has a non-depolarizing agent on board. Military, they use the anticholinesterase intoxication because there's, of course, nasty drugs that are called organophosphates that are used to gas people. Okay, pralidoxime is the one that's used. Okay, and the reason it's used preferably than atropine is because it is able to break off the phosphorylated acetylcholines from the organophosphates. So it takes something that's pretty much irreversible and makes it reversible, okay, which is pretty cool. It does not always antagonize the CNS effects, which is a little bit worrisome because it doesn't cross over the blood-brain barrier very much, but at least it allows the person to spontaneously breathe. So during that time, while you're waiting for that other agent to take off the effect in the central nervous system, you need to maintain supportive care. People have received this quite often in the field. They don't know exactly what the long-term effects on this on the military personnel is. Some people actually are concerned about this in the sense that we're just using the military personnel to a certain degree as guinea pigs, but they've actually noticed that they've had some increase in neurological dysfunction in some individuals. So it's not everybody seems to be having a problem with it, just some people. You also can have what's called the central anticholinergic syndrome, okay? And that's when tertiary amines actually penetrate into the brain. So when you give your anticholinergic with your drug, when you give atropine, it actually may cause a problem, okay? If you're giving scopolamine for sedation or for postoperative nausea, vomiting, you may also have a problem. The good thing is that you can diagnose it pretty fast because they have these pretty clinical symptoms: hot as a hair, dry as a bone, which just means that their mouth is real dry. They're red as a beet, okay? They're blind as a bat and mad as a hatter, okay? So that's how you remember it. Just sort of sing that a few times so you memorize it, and then that's your acronym. And the way you reverse this is by using physostigmine. Physostigmine is a centrally acting anticholinesterase drug, so that can increase central levels of acetylcholine and reverse the effects of these kind of agents. Physostigmine is a tertiary ammonium, and for that reason it has no charge. You can see the molecule up here. It has no charge, so as a consequence can penetrate the blood-brain barrier. It comes usually in 1 milligram per cc vials like this. They usually come in glass ampules. And you give 15 to 60 mics per kilo IV to treat restlessness and confusion associated with atropine scopolamine. The duration of action, unfortunately, is shorter than the anticholinergic drugs, so many times you have to give a repeated dose. Physostigmine may reverse the depression ventilation associated with opioids and also may increase the state of consciousness in patients sedated with diazepam, although it's not as reliable. Okay? But physostigmine is really a good drug for us. It is a good reversal agent for these kind of effects. So you need to memorize this one. This one you are going to use in clinical. It's going to happen to you one day that you're going to give somebody scopolamine that you expect everything should be fine, but they react in a very bad way, and they end up having what's called central anticholinergic syndrome. Now, this last few slides are pretty much, I think these are throwaway slides. We never use these drugs. So I'm just going to mention them very, very briefly. Okay? These synthetic cholinergic agonists are something that, they're not used in anesthesia. They are agonists at the postganglionic parasympathetic nerve endings. They're used to treat things like glaucoma and things like that. So they're topically usually applied to the eye. Precautions should be avoided in asthma, coronary artery disease, and peptic ulcer disease. It increases the risk of developing peptic ulcer disease. You have carbachol and bifenacol. These agents are totally resistant to hydrolysis by acetylcholinesterase or plasma cholinesterase. They're somewhat selective to smooth muscle of GI and GU. Okay, they're effective. There's less cardiac effects. And bifenacol is used to stimulate smooth muscle of the GI tract and urinary bladder. And carbachol is used to treat eye, to treat narrow angle glaucoma. That's where we see a lot of it. Okay? Does it really cause a problem for us too much? And the answer is most of the time, not really. Okay? Pilocarpine has predominant muscarinic effects. Sweat glands seem to be sensitive to this drug, and it's a miotic, which causes sustained decrease in intraocular pressure. So again, that's where it's used as well. So these are agents that are used more for eye stuff. So you're never going to use this in your clinical practice, so I wouldn't worry about memorizing too much. I'm mostly not going to ask any questions on these agents at all, because I think they're just not something you have to know. Okay? But the book included it, so I just threw it in. Okay? Let's go on to the next subject. What time is it right now?